During this session, we're going to talk about the anatomy and physiology of pregnancy. We're going to talk about some of the changes that mom goes through and some of the things that nurses can teach our patients to help manage those normal changes. Some of the terms that we need to know to get started are specifically gravity and parity. Gravity is how many times has a mom been pregnant. Parity is how many of those pregnancies have lasted to at least 20 weeks and beyond. Multigravida is somebody who has been pregnant more than once. A nullagravida is somebody who is in her first pregnancy, and a nullipara is somebody who has never been pregnant. Other terms that we need to make sure we understand is post-term or post-dates. That means a pregnancy that has lasted beyond 42 weeks gestation. Preterm is a pregnancy that has reached 20 weeks of gestation but ended prior to the completion of 37 weeks. Term is a pregnancy from the beginning of week 38 through delivery. Viability, we talked about last time as the capacity of this infant to live outside the uterus. We are currently calling that at about 23 to 24 weeks. And then a miscarriage and an abortion medically are the same thing. It's a pregnancy that is lost prior to 20 weeks gestation. Now keep in mind how politically charged the word abortion is in our society today. So be very careful when you use this term. Imagine, if you will, this mom who has gone through years of infertility, has gone through tens of thousands of dollars trying different fertility mechanisms. She's managed to get pregnant 3 times, but she's not managed to carry those babies to term or to even be delivered. So they're miscarriages. And then we callously ask her about the number of abortions she's had, or she hears us classify her pregnancies as an abortion, and they're very quick to tell you, no, I didn't have an abortion, I had a miscarriage. Because in their mind, an abortion is something that somebody has done deliberately, where a miscarriage was beyond their control. So how do we ask our mom these questions so that we make sure that we're not insulting them or using a term that might be painful? We ask them to tell us how many times they've been pregnant, and then to tell us about what happened during those pregnancies, tell us the outcome of those pregnancies. And so she'll tell you that she's been pregnant 6 times. She's had 2 term babies, 2 preterm babies, and a miscarriage and an abortion. And so I ask her to tell us about those. So she tells you that she knows that, her first baby, she was due June 1st, but she delivered on May 25th. Well, that's prior to the due date, so in her mind, she may be thinking that's a preterm infant, so she tells us that that was a preterm delivery, where we know, based on the definitions that we use, that that was technically a term baby. And then she may also think, another woman may think that, well, we've made it past halfway through the pregnancy, I made it to 30 weeks, so that's term, because that's more than halfway through. And so we want to know specifically when she delivered those babies. And then they will tell you, a lot of times they'll tell you the difference between they had an abortion and they had a miscarriage. And if we know, we want to ask how far along those were when we ask her to describe that history. So there's 2 different ways that we can write her OB history. We can talk about gravida and para. Gravida, remember the number of pregnancies that she's had. Para, the number of pregnancies that made it to at least 20 weeks gestation. But that tells us an overview, but it really doesn't give us real specifics. So a better way to document their history is the GTPAL. And this will tell us more information about the outcome of those pregnancies. Now, our hospitals in the Metroplex, and I'm not sure exactly what they're using, like down in Houston, down in San Antonio, but a lot of our hospitals use kind of a combination of the 2. They talk about gravida para, and then somewhere later in the history, they're going to describe the outcome of those pregnancies. When we're talking about gravity, regardless of whether we're talking about the GP or the GTPAL, remember to count the current pregnancy. So in the GTPAL, G stands for gravida, how many pregnancies, not how many babies. If she's pregnant with twins, that's still only one pregnancy and only one delivery type. So term is the number of babies that were born after starting on week 38. Preterm, number of babies that were delivered after 20 weeks, but prior to 37 completed weeks. So keep in mind, if she was 37 plus 6 today, and she delivered today, she would be preterm. But if she delivers after midnight tonight, that puts her into her 38th week of pregnancy. So after midnight tonight, she is now considered a term pregnancy. Number of abortions, that's whether we're talking about spontaneous, therapeutic, or elective. And then the number of living children at the time that you're asking her history. Remember, in GP, the P stands for para, the number of pregnancies that survive to 20 weeks. In the GTPAL, the P stands for preterm deliveries, the number of pregnancies that delivered between 20 and 37 completed weeks. So let's take a look at this example and see if we can put this in context for you. And so the best way that I have figured out to write down somebody's GTPAL score is to write those initials, either from top to bottom, or if you're going to go from left to right, give yourself enough space in between each of the letters so that you can add a tick mark when you're talking about your pregnancies. So Alice had a positive pregnancy test today, so she's at least a gravida 1. Her first pregnancy, so we're going to add another one to the gravida. Her first pregnancy delivered twins at 32 weeks. Both are alive and well. So she's a gravida 2. This is a preterm delivery, so we have 1 after preterm. And then we have 2 living children at this time. So we're going to have a 2 after the L. Her second pregnancy, which now we need to put a third tick beside the G for gravida. Her second pregnancy delivered a single infant at 38 weeks, so that we know that that's term. So now we need to add a tick mark next to the T. However, that baby died of SID, so we're not going to add any to the living children number. Her third pregnancy, which means we should now have our fourth tick mark next to the G, was a stillbirth at 40 weeks. That's a term delivery. So we now we've got G4 and T2, but we're not going to add another one to the living. And then we have the fourth pregnancy, which makes it a gravida 5, and this was a miscarriage at 12 weeks, so this is a delivery prior to 20 weeks, which means this is an abortion. So we should have 1 after the A. So her GTPAL score is, and if you see down here at the bottom, it's written as 5-2-1-1-2 or 5/2/1/1/2. And then when we say that, we say her GTPAL is 52112. Since we all have the same understanding of what this stands for, what is considered gravida, what's considered term, what's preterm, the definition of abortion, we don't have to say that she's a G5, T2, P1, or she's a gravida 5, term 2, preterm 1. We can just say 52112. And we can write it just like that in the record, and it's clear and it's understood what that means. So here's an example. This is a woman that comes in with a positive pregnancy test today. Her first child was born at 38 weeks and is alive and well. So this is a term baby. Write out your GTPAL. So she had a positive pregnancy test today. Her first baby was born at term. So that's a gravida 2 with 1 term, is alive and well. So we have 1 after the L. Her second pregnancy, which makes her gravida 3, resulted in triplets born at 28 weeks. So that's preterm. So we have 1 preterm. 2 of those babies out of the triplets died. One of them died at day 2 and the other one died at 3 weeks. So we have one living child from that pregnancy. So now we have a G3, T1, P1, A0 at this point, and we have 2 living children. Her next baby was born at 40 weeks, so that's one more gravida, that's one more term. And because it doesn't state anything about the outcome or if that child is living, we are going to assume that that is a living child at this point. And her last pregnancy, so again, put another tick mark next to your G, ended in a spontaneous abortion about 9 weeks. And so that's an A. So she's a G52113. Term 2, preterm 1, abortion 1, and living 3. Don't forget that she had a positive pregnancy test today. Now, when you're looking at test questions, if it talks about a mom, the woman walks up to L&D and here's her following history. If it doesn't, even if the question doesn't state that she is pregnant today or had a positive pregnancy test today, if she is showing up on labor and delivery, we can assume she is currently pregnant. So we have that gravida, and then we add the other pregnancies that she tells you is her history. Another term that we need to understand is Nagel's rule. This is how we're going to estimate mom's due date. Come up with an EDC or an EDD. We're going to take the first day of her last normal menstrual period. We're going to subtract 3 months and add 7 days. So when we ask her when the first day of her last normal menstrual period was, well, I had a normal period in January. And I had a weird one in February. I mean, it wasn't quite normal. I spotted off and on for a day or two. It wasn't like my normal period. So that's not a normal period, so we're not going to count that February one. We're going to count the one in January. And so we're going to subtract 3 months from January. Now when you do this, if you're going to count on your hand, please make sure you don't count January. We're going to count backwards from January. So that takes us to December, November, October. So the EDC, her birth month, is going to be October. Then say she said that the first day of her last period was January 10th. So we're back to October. The first day of her period was the 10th, so we're going to add 7 days to that. Her EDC is October 17th. So here's an example. Her last normal menstrual period started on May 31st. She had no prenatal care and comes in today complaining of contractions. The first thing that we're going to do when somebody presents to L&D is figure out what her due date is based on when she says her last normal menstrual period is, if she knows it. If not, we need to do ultrasounds and determine what her due date is. So how are we going to figure this out? So we're going to go backwards 3 months from May. So that takes us from May back to April, to March, to February. Okay, February 31st. Oh my goodness, we don't have a February 31st. Okay, it's the end of the month. We're going to add 7 days. So it's going to take us to March. So it would be March 7th. Remember that this is an estimated date. Please don't get hung up on the fact that you're trying to figure out how many months in this time frame had 30 days versus 31 days, whether the February in this calculation had 28 or 29 days. It doesn't matter. Subtract 3 months, add 7 days. If it's on the 30th, add 7 days, so it's going to be the 7th of the next month. If it's the 31st of the month, add 7 days. So it'll be the 7th day of the following month. Don't get hung up on whether we're talking 30 or 31 days. This is an estimated date. If our calculations put us into a new year, please make sure that you change the year so that she doesn't have a due date prior to her last normal menstrual period. There's going to be some examples on Canvas that are already open for you for practice for this and for seeing if you understand GTPL. Please practice those so that you can see if you understand this concept, because you will probably see these kind of things again on any type of test that has anything to do with OB. And then the answers to these, so that you can check yourself, will open within a few days after that. When mom goes to the drugstore and picks up a pregnancy test, she's picking up a test that is going to test her urine for this hormone called human chorionic gonadotropin, HCG. Those levels tend to double every 48 to 72 hours up until about 60 days after conception, and at that point they're going to dramatically start to decrease. If this is her first pregnancy or her other pregnancies have been without complications, she doesn't have a big history of early pregnancy losses, then we're going to get her hooked into the prenatal care system and start setting up her appointments. However, if she has a complex history of early pregnancy losses and previous pregnancies, we may need to investigate a little bit further. So we would do serum HCG levels. The urine pregnancy test is either going to be a positive or a negative. The serum HCG, on the other hand, is going to give us a specific definitive lab value. And so they're going to monitor that to make sure that we have this doubling every 48 to 72 hours to tell us if our pregnancy is progressing as expected. If we have abnormally high levels of this HCG, we could have multiple gestation. We could have a pregnancy with a potential abnormality such as Down syndrome or maybe a hydatiform mole pregnancy, and we'll talk about that more in a couple weeks. An abnormally low level could mean that this is a pregnancy that is at risk for spontaneous abortion, SAB, or it could be an ectopic pregnancy. Here's a picture of some of the many different types of pregnancy tests that are out there. These are the exact same ones we use at the doctor's office, by the way. So what are some signs and symptoms of pregnancy? You're going to need to know the difference between subjective, objective, and diagnostic, also known as presumptive, probable, and positive. Subjective are things that mom feels. She feels bloated. She feels pregnant. Objective are signs and symptoms that are related to pregnancy, but they could be something else, such as missing a period. That's a sign and symptom of pregnancy. It's a physical sign, but it's also a sign that could indicate something else other than pregnancy is going on. And then we have diagnostic changes, and those are the ones that can be nothing besides pregnancy. There is no other reason to have this symptom, such as fetal skeleton on an ultrasound, hearing the fetal heart rate with a Doppler. That can't be anything besides pregnancy. We're going to talk about some of the hormonal, structural, and adaptive changes that women go through, and some of the things that we can teach mom to help her adjust to these changes. One of the most obvious changes in pregnancy is the change of this uterus. In a non-pregnant mom, her uterus is the size of her fist. But by the time she reaches term pregnancy, that uterus is stretched to encompass this 8-pound kiddo, the placenta, all the amniotic fluid, and as we can tell by looking at mom from the front, the top of her uterus is up underneath her ribs, up into her stomach. If we were to weigh just the uterus in a non-pregnant mom and a non-pregnant woman, that's going to be about 2 ounces. But by the time she reaches term, that uterus has undergone such tremendous change. It's developed such increased muscle mass, getting ready for the work of the contractions that's going to push this baby out. That muscle mass has grown this uterus that empty, it's going to weigh 2.5 pounds versus 2 ounces. In the non-pregnant mom, the capacity of that uterus is about 10 mLs. At term, it's 5 liters. Tremendous amount of change. One of the ways that we continue to monitor mom's health in this pregnancy and the fetal health during this pregnancy, we do this thing that's a very non-invasive assessment at every prenatal visit, and it's called measuring the fundal height. We're going to measure from right here, the symphysis pubis, up to the top of her uterus, her fundus. Where is that fundus at? And we call that the fundal height measurement. So in a non-pregnant woman and in an early pregnancy, it's not palpable. It's still down in the pelvis. So about week 12 or so, it's coming up out of over the pelvic rim right here, and it's going to be increasing as this gestation continues to go along. So by the time she's about 20 weeks gestation, her fundal height is about at the umbilicus. And so we say that the fundal height is about 20 centimeters or centimeters, and that's usually right about the umbilicus, and that's where she should be at 20 weeks. So that tells us that baby is probably growing appropriately, placenta is growing appropriately, all the amniotic fluid. And then every time she comes in for an assessment for her prenatal visits, we're going to measure her fundal height and make sure that that is gaining appropriately like we think. And that's going to pretty much measure out to how far along gestationally she is. So at 36 weeks, she should probably measure right here at 36 centimeters from her symphysis pubis to about 36 weeks. Sometime after 36 weeks, that baby can drop down into the pelvis as it prepares for labor and delivery and birth. Then it's going to drop. So we could see that we go from 36 weeks. I'm sorry, I keep losing my little cursor here. We go from 36 weeks, and now it might actually drop. And we're not getting concerned about that if we've had good interval growth throughout her pregnancy. Now, if she comes in and she measures 20 weeks, but we know based on an early ultrasound or based on a very definitive last normal menstrual period that she should be at 24 weeks, but she's measuring very small all of a sudden, then we're going to send her for an ultrasound to determine the health of that pregnancy. On the other hand, if she's measuring 24 weeks, but we know she should only be 20 weeks, again, we're going to send her for an ultrasound to determine what's going on with this pregnancy. Now, some of our babies are just constitutionally small or constitutionally large. Once we determine that the pregnancy is okay and those measurements are not quite equal, if they're off by 2 weeks, they should be off by 2 weeks every time we measure her. And if she falls off that growth curve, we're going to send her back for another ultrasound. So what do you think could alter this? What could make a baby or a uterus larger than what we think it should be? We call that large size greater than dates, or size equal dates if she's right where we think she should be. Something that could really alter that is, say mom's carrying more than one baby in there. That uterus is going to grow faster than what we think. She has too much amniotic fluid. Sometimes mom's maternal obesity is going to change this a little bit. On the other hand, less than what we think she should be, size less than dates, we have to determine that first this is a healthy pregnancy with our ultrasound, but it might just be a constitutionally small kiddo. Or it could be that mom doesn't have enough amniotic fluid and we would need to take precautions to help work on that and identify what to do about that. So after about 16 weeks of pregnancy, that uterus starts to contract. And those contractions, we call those Braxton Hicks contractions, that help to increase the blood flow through the placental bed to help increase the amount of available nutrients and to be able to carry off baby's waste products. What we need to instruct mom on in our prenatal teaching, or if she were to call the clinic or labor and delivery saying she's having contractions, is one, we would want to teach her the difference between those normal Braxton Hicks contractions and possibly preterm labor. If she calls in and tells us that she's having contractions, we're going to ask her, has she been able to time them? Yes, they're about every 10-15 minutes. Okay, lay down on your side, drink 3 to 4 cups of water, 3 to 4 8-ounce cups of water, and see if those contractions slow down or go away, and then call us back. Braxton Hicks contractions they're going to go away when she changes her activity level and when she hydrates herself. Preterm labor contractions, on the other hand, don't go away because of hydration or change in activity. And we're going to tell her that if she has more than 6 contractions in an hour after she's laid on her side and she's hydrated, if those contractions continue and she has more than 6 in an hour, we want to see her to rule out preterm labor. If she's in preterm labor, we want to know that so we can treat her and attempt to stop that labor. The cervix also undergoes tremendous amount of change. It increases the amount of granular tissue, starts to secrete a mucus plug, and the mucus plug is exactly that. It's mucus at the cervix that's going to prevent the invasion of organisms from the vagina up into the uterus. Blood flow is going to increase. This causes a softening of the cervix, and it causes a blue-purple color to the cervix. Instead of that nice pink color, it's going to be kind of bluey-purpley. And that's just that increase in blood flow. These are signs that we're going to see early in pregnancy, usually at their first prenatal visit, because they're going to do all their cervical cultures. They'll probably do a pap smear. And so we actually see this when we are using a speculum to get our specimens and our pap smear. We don't typically identify this at any other point during this pregnancy because we don't actually look at that cervix at other points if there's nothing else specific going on. When she's in labor, we're not going to do we'll do a pelvic exam, a vaginal exam, but we're not going to do a speculum exam where we actually get to see the cervix. Friability increases, which means that it's a little bit more, the cervix is a little bit more prone to bleeding than it was previously. So this can happen after a vaginal exam, and it can happen after intercourse. So we teach her during prenatal visits, or if she were to call the clinic or the hospital because she was having a little bit of spotting, first we would ask her to describe the spotting. Well, it's there when I wipe, or I've noticed blood in my panties. Well, have you had to wear a pad? Are you actively bleeding? No, I think I'm just spotting. This can be normal after intercourse or after a vaginal exam. So we're going to ask her, when was the last time that happened? Typically, this has been happened within the last 48 hours or so, 24 to 48 hours. So we're going to tell her if she's not actively bleeding but spotting, keep an eye on it over the next day. It should go away. If she's notices the bleeding is increasing, she probably needs to call us or come in to be evaluated. And so this is just a picture, the cervix of a non-pregnant mom and the cervix of a pregnant mom. We can notice that there's a big difference in that cervical tissue. Vagina also undergoes tremendous amount of change during this pregnancy. It hypertrophies, it changes in shape and size. Most of that change isn't going to be seen though until delivery. Increased amount of tissue, increased amount of vascularization, meaning increased blood flow, loosening of all the connective tissue so that it will allow it to accommodate this 8 and 9 pound baby coming through, increased amount of secretions, and we're going to talk about that next. But these changes also lowers the pH of the vaginal environment, and that helps prevent bacterial infections. However, that lowered pH also increases the risk of Manila infections or yeast infections. The increase in those secretions, we call that leukorrhea. That's an increase in white or gray discharge. This should not be foul smelling. It should not be itchy. It should not be making her uncomfortable, other than the fact that she's just a little bit more aware of that. And all that is a way of helping protect the environment that that baby's in. Now, if they call us or they ask us when they come in for appointments and things about they're concerned about this increased discharge, we first need to ask to make sure it's not itchy, foul smelling, not causing her vagina area to be raw or anything. Then we can reassure her that this is a normal change in pregnancy. Please don't ever have somebody have a complaint and you just pass it off and go, oh, that's normal. Make sure you ask enough questions about their complaint that you can state that this is a normal change. There is also a noticeable change in sexual response for most women. That's due to the hormonal changes, due to the increase in vascularization, Sometimes this isn't seen until about the end of the first trimester going into the second trimester, sometimes because those physical changes mom's going through make it too uncomfortable. Nausea and vomiting. Who wants to have sex if she's nauseated? If her breasts are real tender, she doesn't even want those touched. And so sometimes it's not until that end of that first trimester going into that second trimester that they actually have this change in response. Now, if they're not having all those symptoms in the first trimester, this can happen early on due to the hormonal changes. We need to ensure that mom understands it's okay to have sex. There is no harm in sexual activity. You have an outline in your book about all the physiologic and physical changes that mom undergoes. These are going to be well defined on your prep sheets. So we're not going to go into great detail, but we are going to look at some of the major structural and changes that mom goes through. Understand all organs in mom's body are going to undergo some type of change due to this pregnancy. The breast, they increase in shape and size, increase in vascularity because of the estrogens and progesterones of pregnancy. The veins become more prominent. The nipples become more erect. The nipples and areola become darker. And colostrum may begin to appear by about the 12th week of pregnancy. Now, as cool as that is, it's also important that we explain to our moms that even though they have this colostrum that starts to appear about 12 weeks, this colostrum continuously is reabsorbed, reproduced, reabsorbed, reproduced. So it's an ongoing change throughout the pregnancy, so that moms don't think that the colostrum baby gets at delivery is the same colostrum that's been sitting in her breast since week 12. The heart also changes size and shape. It's displaced forward and to the left. The heart rate increases and the blood pressure decreases. What's really important is that you understand that this increase in heart rate and the drop in blood pressure is not a sign and symptom of shock, as you've learned in your other courses, but it's a normal change in pregnancy. If you're going to call a provider about a blood pressure issue, whether we're talking about somebody who's pregnant or not, please make sure before you call him about your blood pressure that you have taken a manual blood pressure. Blood pressure machines are usually fairly accurate, but the higher the blood pressure, the less accurate your machines are. So always make sure you have a manual BP, because the first thing your provider is going to do when you call him about a blood pressure is ask you if that was the machine or a manual. Another change in our cardiovascular system is the components of the blood. By the time mom's about 20 weeks along, she has got about a 40 to 50% increase in the amount of blood volume that she has. So about 1,000 mLs of extra plasma, which is really good when you think about it, because now all of a sudden she has this whole other shunt that she has to fill, this placental bed that she has to fill. And she could not do that with her normal blood volume. So the hormones of pregnancy causes this increase in volume, and there's also a corresponding increase in the amount of RBCs that are produced. More volume than RBCs is produced, so we have this dilutional effect in the RBCs. In actuality, there's more RBCs, but when we're looking at our counts, it looks lower because there's more solution that all these are floating around in. So for pregnancy, a normal hemoglobin is 11 to 14, and a normal hematocrit is about 32 to 42. They're not considered anemic until their counts are less than 11 and 33. Along with this increase in RBCs, it's important to understand that most women cannot get the amount of iron that they need in their diet alone to have this increase in RBC production. So we frequently prescribe prenatal vitamins and iron. And the iron is so that she has all the components that she needs to make all these extra blood cells. So as this slide shows, we have a 30% increase in our RBCs if mom has taken iron supplements versus 18% if she's not. Leukocyte production increases. Not only do we have a normal increase in vaginal discharge, we also have an increase in the number of the white blood cells in her blood. And so 10 is usually considered the upper norm for a WBC count. In pregnancy, It can be as high as 15 and it should not be considered infective. Now, we're going to investigate, make sure we don't have a temperature, we don't have signs and symptoms of an infection anywhere. And without signs and symptoms, we're not going to be concerned with a WBC count up to about 15,000. And we're going to treat symptoms, not lab values. Fibrinogen and fibrin also increases, where the fibrinolysis decreases, making mom hypercoagulable during pregnancy. So she's at increased risk for DVTs. We're going to teach her the same thing that we teach like our post-op patients. Don't cross your legs. Make sure you're getting up and moving around, not being sedentary. Make sure you stay hydrated so that the risk of DVTs decreases. Now this is a really important slide, and we're going to see this a couple, 2 or 3 times throughout this semester. So we're going to camp on this for just a minute. This is a very important slide. After about 12 weeks of pregnancy or so, if mom lays flat on her back, the weight of that uterus with the baby, the increase in muscle mass, the amniotic fluid, the placenta, the cord, all of that, it actually puts pressure on the aorta and the inferior vena cava. Now, the aorta can survive this a little bit better because it's got much stronger structure. So it can survive this a little bit better than the compression of the inferior vena cava. So mom's heart pumps. She pumps blood out. It goes out to the placenta. It goes out to her lower extremities. However, it has trouble coming back from her lower extremities because of the weight of this uterus and its contents on the inferior vena cava. So cardiac output returning to the heart, the decreases. So mom thinks she's in hypovolemia, so she starts shunning her blood thinking that she's in trouble. Now think about CPR and think about what your vital organs are. Heart, lung, brain, kidney, liver. Uterus is never on that list of vital organs. And so while the uterus is going to get some blood flow, it's not going to get a good amount of blood flow. Her heart and her brain, etc., are going to get the preferential blood flow, which could mean that this baby drops below what he needs for incoming O2 and mom's ability to pick up his waste products and carry it off. And so our baby can get in trouble because mom's laying flat on her back. So we always want to think about getting mom tilted, as you see on this bottom picture, a hip wedge so she's not flat on her back, or get her in the lateral position where she's actually on her left side or her right side. So if you think about if mom were to go to the OR, we can't have mom go to the OR to have a cesarean delivery and have her on her side. So this is when positioning aids are going to be really important. We have positioning aids in the OR. That it's like that V-shaped wedge that we put under one hip or the other to get her tilted off flat on her back. Because if you think about it, we get her to the OR, we then have to scrub, we have to put in a Foley in, we've got to get her draped, we have to wait for the surgeon to come in. And so she can be on her back for 5, 10, 15 minutes before they get ready to start the surgery and actually get the kiddo out of here, which is enough time that means that we're not getting good blood flow through the placenta into our kiddo. I've seen in the ambulances that when we've had these moms in the ambulance, we can tilt them just enough either by a rolled up sheet or putting an IV bag or 2 under one of her hips to just tilt her just enough. Respiratory system changes. Even before that uterus grows so much that it's putting pressure on lungs and all those kind of things, that diaphragm's going to elevate by about 4 centimeters or so. And the estrogens of pregnancy are going to relax the ligaments of the rib so that the ribs actually flare out. Mom's respiratory rate might increase just a little bit. She's bringing in oxygen for 2. She's offloading the waste products for 2. Not uncommon to have some nasal stuffiness and nosebleeds. Like we said, the respiratory rate may increase, and then the sensation of dyspnea can occur. The sensation occurs much more frequently than actual dyspnea. sometimes they just feel short of breath, but there's no actual physical impediment to them being able to breathe. They've increased their weight, they've got pressure on their ribs, they've got pressure on their lungs, so they just feel short of breath, yet their O2 saturation and things are just fine. Pregnancy is a state of partially compensated respiratory alkalosis. If you'll remember, normal pH for an adult is 7.35 to about 7.45, and our pregnant women automatically changes to about 7.4 to 7.45. And this alkalinic environment enhances the ability of mom to be able to offload oxygen at the placenta for the baby, and it increases her ability to pick up baby's waste products like CO2 at the placenta. The more acidic her blood, the less likely she is to be able to offload O2 or pick up waste products. Because she's already in partially compensated respiratory alkalosis, things like asthma or pneumonia, COPD or type symptoms, mom's going to decompensate much quicker. Ask any pregnant woman what's the first thing they do when they get anywhere, and it's to find the bathroom. Very early in pregnancy and in the last half of the last trimester, there's an increase in the amount of urgency and frequency of needing to urinate. Now, in the early part of pregnancy, it's not so much the pressure on the bladder as what it is some of those hormonal changes. In the latter part of the pregnancy, when that baby drops into the pelvis, then it actually is the physical pressure on that bladder. And we need to teach them the difference between that normal frequency and urgency of pregnancy versus the frequency and urgency of a urinary tract infection. And so with a urinary tract infection, they go to the bathroom, they leave, and just in a very few minutes, 5, 10, 15 minutes, they have to go again. And it's because that bladder is so irritated that anytime this infected urine hits it, it has to spasm and get rid of that. And so they turn around, they go right back to the bathroom, but they don't have normal volumes. It's just a little drip drop. But with a UTI, they also have bladder cramping, they might have urethra pain or burning when they're urinating. The frequency of pregnancy doesn't hurt, doesn't cause burning, doesn't cause any discomfort. And typically, even if they just went to the bathroom 30 minutes ago, when they go again, it's usually normal volumes. It's not just a drip and a drop. There's greater reabsorption of CO2 to help meet fetal needs. And remember, we talked about the increase in blood volume, 40 to 50% increase by the time she's about 40 weeks or 20 weeks along. This increased amount of sodium reabsorption helps with that. Remember, mom's getting rid of the waste products for 2. The renal blood flow is best when mom is on her side. And this renal blood flow is getting rid of mom's waste products as well as baby's waste products. So she's helping baby get rid of the waste products through respiratory and through urinary means. So it's best in the lateral position. It's the worst in the supine position. We already know from our earlier slide that supine is not a good position for pregnant women to be in anyway. It's normal for moms to spill just a trace amount of sugar and a trace amount of protein in their urine, and we don't get concerned about that as long as it's trace. Once it gets to 1+ and higher, then we have to investigate to see if there's something else going on, diabetes or a change in her diabetic status. An increased amount of protein in her urine can signify that she's got preeclampsia, and we're going to talk about that next week when we talk about some of our high risk, or actually 2 weeks from now when we talk about high risk conditions. Moms say that their hair and nails, skin have never been better than when they're pregnant. Their skin kind of clears up, their hair grows better, it's shinier, their nails are stronger and grow faster. Lots of changes based on estrogens and progesterones of pregnancy. The pigmentation of the breast, the nipples, the areola area, all those change. Some of our women get a dark line running from their symphysis pubis up to their umbilicus, maybe a little above their umbilicus. We call that linea nigra. It's just a dark line caused by these hormonal changes. Those will tend to lighten and return to normal Maybe not exactly like they were, but they're not going to be as dark as when she's pregnant. The skin system that gets striae gravidarum, those are stretch marks. Now, some of the students, when they're trying to come up with diagnoses for our moms, they'll come up with altered body image. And when I question them on that, is that something that mom said? Students frequently will say, well, no, she's just got all those stretch marks and she's got a real flabby tummy, and so I just figured she'd probably have a change. And some of the women that have these babies are actually proud of those stretch marks, proud of that flabby tummy. Their body has done some tremendous stuff by creating this kiddo. They're proud of what their body's done. These are not something that they're ashamed of. So let's not body shame them because we think that they might be concerned about those. It could be an accurate nursing diagnosis, but make sure it's based on the fact that mom thinks that, not that you think mom thinks that. They can have palmar erythema. Their hands, the palm of their hands are very, very red. That's due to the vasodilation, increased blood flow at the surface, so their hands are just red. It doesn't mean anything. So here's a picture of striae gravidarum. Those are those stretch marks. Now these are darker. As she gets more remote from delivery, the further postpartum she is, those will change from those dark lines like you see. Those will turn into silvery lines, kind of almost look like little hair lines, not wide like that. They might sweat a little bit more, have a little bit more oily face, even though their complexion is clearer. They might have a little bit more oily face. Progesterone and relaxin cause loosening of the pelvic joints. If you think about if you've ever watched Bones or CSI, Law and Order, any of those kind of shows, and all they see are bones, they go, oh, this was a prepubescent female, or this was a teen female. How can they tell that? They can tell that based on the shape and size of the pelvic bones. In women, the joints in the front and the back of her pelvis, those are joints where they're fused in men. The good news about this is it allows that pelvis to change shape so baby can slide through there, and it can change to accommodate whichever size kiddo is coming through. It's this relaxation of these joints that causes that pregnancy waddle. They're not waddling necessarily always just because of the size of their belly and this baby. They're waddling because their joints are a lot looser, getting ready for the process of labor and delivery. They also get this lumbar curve due to the growing shape and size of this uterus. This has to relax a little bit to allow that. That helps her keep her center of gravity. Now her center of gravity has shifted, but all of this has to change in order to carry this baby and to be able to get her in locomotion. Some of our moms also, these are the abdominal muscles up the front of mom's stomach. Sometimes during pregnancy, there's a separation of these muscle sheaths. We call that diastasis recti. It's a separation of the abdominal muscles. Sometimes right through here we can see bowel, sometimes we can see peristalsis. We can also sometimes see baby moving a little bit easier because the uterus isn't covered up with this abdominal muscle. Due to this increase in the fluid and things in pregnancy, there can be compression of the nerves, like in the hands, causing carpal tunnel syndrome. The weight of this uterus puts pressure on the sciatic nerve, so they have sciatic pain. Those changes in the posture, the loosening of those joints, the loosening and the sway back in her muscle posture can be uncomfortable. And so that should all go away after delivery. We've talked about some of the normal changes in pregnancy being that we have this increase in blood volume. Well, part of what goes along with that, there's also a vasodilation that occurs. So if mom is laying flat on her back, or she's been in like a lying down or a sitting down position for quite a while, and then she sits up or stands up really rapidly, then she can have some faintness or syncope because her body doesn't vasoconstrict like it does in the non-pregnant, so she gets a little woozy when she stands up. So we tell her to rise slowly. One of the biggest changes that most people are aware of with pregnancy, besides the change in the uterus, is nausea and vomiting. The hormones of pregnancy cause a change, probably in carbohydrate metabolism, that leads to morning sickness. So conventional wisdom might be saying, have crackers at the bedside and have some crackers before you get up in the morning. That should help with some of that morning sickness. Well, one, we know morning sickness is probably not a very good description because some women suffer from this all day long. The good news is, although this is the most common change in pregnancy, some women can have nausea. They have it once a week. It comes, it lasts for 5 minutes, it goes away, and then they're good. Other women, this is something that they fight all day, every day. But the good news is, most of the time, by the time they're out of their first trimester, those hormones have calmed down, and so the nausea and vomiting goes away for most women by the end of their first trimester. If this change in carbohydrate, and if this morning sickness, they're sick before they get out of bed, is due to low blood sugar, why don't we fix the low blood sugar? Give them a small protein snack at bedtime so that through the night their sugars don't drop as far, therefore they're not as nauseated or have vomiting when they wake up in the morning. Another change is taste and smell may be altered. Something that they loved the taste of before is extremely repulsive right now. Something that they loved before to smell, like that coffee first thing in the morning, oh, that just causes them to be so sick they can't even think about coffee. We know that a lot of women suffer from GERD type symptoms or heartburn, and that's because the cardiac sphincter relaxes during pregnancy, so they have a lot more backwash of the stomach contents and the stomach acid causing the heartburn. So what do we tell them to do to help fix that? One, we want to tell them to, instead of 3 normal meals, we want to break it down into 6 small meals throughout the day. Don't eat and drink at the same time. Separate food and fluid by at least an hour, and that should help with a lot of that. We also know that we want most women to be taking their iron, and that iron can be very distressing for some women. And so we tell them to take it on an empty stomach, and they say they can't because it kind of makes them sick, it makes their tummy hurt. See if we can get them to take it at bedtime. That way they're sleeping when the iron is causing the issue. They wake up, they're fine, they haven't been distressed by it. If all else fails, then they can take it with something small, but it should not have anything that's got calcium in it. We really don't want them to take it on a full stomach. We don't want them to take it with the meal because less iron is absorbed that way. Maybe a small snack when they take it so they have something on their stomach, but it doesn't interfere in a massive way with the absorption. That growing uterus puts pressure on the large and small intestines, which slows down transient time. The longer something's in the GI system, the more fluid's going to be reabsorbed, therefore leading to constipation. So what are we going to tell her? We're going to increase our fluids and our fiber. You would never tell any patient to increase fiber without also instructing them to make sure they increase fluid as well. Get up, move around, get those bowels activated. Gallbladder empty and slows down, so they're more at risk for gallstones. And so who's most at risk are obese women, women with Hispanic ethnicity, and are women that are AMA. That's advanced maternal age. It's not against medical advice. If you see AMA related to OB, we're always talking about a mom who's going to be 35 or older at the time of delivery. So the endocrine system is responsible for a lot of these changes. Eventually the placenta is going to take over and be producing some of its hormones that's going to help maintain this pregnancy as well. But these hormonal changes that cause a lot of these signs and symptoms and affect these changes in mom's body, those are required in order to have a healthy pregnancy. One of the important hormones that doesn't get enough attention is progesterone. A lot of our moms that have a history of repeated miscarriages early in pregnancy or in early mid-trimester pregnancy losses, it's due to progesterone deficiency. And so what do we do to treat it? We give mom progesterone. Another issue that we see lots more information on in recent years is maternal hypothyroidism. Hopefully, if mom's had preconceptual health care, we've tested her to make sure her thyroid is functioning well. If it's not, we're getting that treated. If mom is, we already know that she has a thyroid issue, we want to test and make sure that she's on the right dose of her thyroid medicine, so she's in the best shape with her thyroid as possible when she gets pregnant. We're seeing a lot more in recent years about how hypothyroidism can compromise fetal neurodevelopment. And so one of the last systems that undergoes changes during pregnancy is mom's immune system. We talked about those super duper WBCs that mom has. We have an increase in the number of WBCs, but those WBCs have an increased capacity to fight bacterial infections. So now we have super WBCs, but they're less able to fight viral infections. And then one of the most amazing things that occurs in mom's body is this local suppression of the immune system. If you think about what a fetus is, what an embryo is, it is 50% foreign material. And so what do most bodies do when they encounter something foreign? They mount this immune response to get rid of this foreign material. Without this suppression of mom's immune system, her body would reject this fetus and habitually lose pregnancies. It's amazing. Her body somehow knows not to get rid of this. It changes to accommodate the fact that we have this foreign material there and to allow this pregnancy to continue, to be healthy, to reach term, to have a normal, healthy, live newborn. Amazing. Women are fascinating creatures to get this work done. And that's the end for this section.